We're going to come back to some of the themes you raised. I love the idea about modeling by example. I think that's exactly what we can say about Mary, is that she embodied many values, curiosity-driven. She was a continuous learning student. She was a mentor. She believed in teaching. So I want to come back to that, but some of those themes at the end of, or near the end. But I want to give everyone an opportunity to make opening remarks, and I think Rick, our next presenter is Rick Birkel from the Rose & Carter Institute. And just as a setup for Rick, I just want to let you know that Mary had a major influence on some of the choices Johnson & Johnson has made in its philanthropic portfolio. And near the end of Mary's life, she became a recipient of care and saw the healthcare system from the perspective of the bedside and had some very interesting thoughts about what that experience was like. And there was no self-pity in what she experienced. It was all about, we got to do better than what we're doing, especially for rural caregiving issues. And so she had a major influence on our thinking at Johnson & Johnson about what we might do when our senior management decided that we wanted to do something in caregiving. Where that landed was helping to move the evidence base in caregiving research, which has accumulated over the last 30 years, into community-based settings. And so we're very proud of our work with the Rose & Carter Institute. So Rick Birkel, can you talk about Mary Harper and caregiving and anything else you'd like to say?
Sure, I'd love to. Well, I first met Mary when I was received a doctoral research grant from HCFA in 1981, and I was in family home care, and I was studying families caring for seniors and Alzheimer's patients at home. And they directed me, of course, to Mary Harper at NIMH. And that was part of the award, was that I would be mentored and talk with Mary Harper. And then so 40 years passed, or 30 some more years passed, and then I ran into Mary again when I went to the Rose & Carter Institute. And Mary was, in fact, the architect of our current work at RCI, which is to implement evidence-based interventions for caregivers. Many of them derive from diverse fields, but many from nursing, from the work of nurse researchers. Mary was passionate about this. But the thing I like to think about is the way her take on evidence-based practice was interesting. She brought a kind of a raw intelligence, what I like to call a raw intelligence, she called common sense, to all her work. She believed in advanced training, and she believed that research was valuable and important, and all the postdoctoral work and training you could get was terrific. But she understood and believed that sometimes that training got in the way of our effectiveness. She saw that people with lots and lots of training and were often bound. They would get bound by conventions, by current thinking, by the rules of the context in which they worked, about disciplinary boundaries. She was continually railing against these limits. So she saw that advanced training and our experience in administration and policy and research sometimes actually bound us more than it freed us. The anecdote in her mind was common sense. So you had to bring both to the task. And common sense in her mind was not something that could be taught, at least not in school, but it was acquired in the course of living, in the course of observing people and being with people. It was common, I always thought, in the sense that it bound people together. Mary really understood that this common sense was something we shared. It was about being genuine in her mind. And she wrote in her last, or she said in her last article, and I want to just comment on this. This is her common sense speech. She said, in 1949, here's the exact quote. She says, in 1949, my dean at the University of Minnesota, which was Dr. Catherine Densford, accurately told me, if you think you had a hard time getting this education, wait until you try to use it. And I just thought that was always the greatest line. It really goes to the heart of evidence-based implementation. We have great interventions. We know what to do. But if you thought it was hard to develop them and test them and evaluate them in the field and do clinical trials, wait till you try to implement them in the field and put them in the aging network and get payers to absorb them and adopt them. That's the real hard part. So Mary said, you know, basically we've had to focus as much of our work not only just on the research side, but that the real heroes in implementation of evidence-based programs would be the workers, the nurses, the social workers, the psychologists who were clinicians, who, if you could convince them that the programs were effective and worked, they would adopt them wholesale and they would embrace them. And so we've brought that really, Rick, I think, to bear on our work at RCI. We work very closely with the research community, but we try very hard to embrace and acknowledge the expertise and the value, the tremendous value added of practitioners who are skilled at implementing and adapting their organizations. They're skilled at finding ways to get the job done in spite of the fact that the policies, the procedures, the funding streams, the training, none of it's there to support the programs. So there has to be continual adaptation. And so I think, you know, Mary's legacy, if you will, at RCI in terms of implementing evidence-based programs for family caregivers comes in our focus on implementation and the balance that we bring to that.
Mm-hmm. Great.
Thank you.
Well, Rick, thank you. I think it's important for us to think about, again, the values that Mary embodied in this issue of common sense. We don't talk about it much these days. We talk about guidelines and you know, algorithms, decision-making trees, or whatever. So I want to come back to this point about common sense and where it belongs, or is there a place for common sense anymore in our health system? But thank you for that.